Good evening everyone. In this video we will try a new format where we will be using a new way by the phone. The new video will be shown by the phone, not by the laptop, so it can be easier for you to see it on your phone. This is the second video of the intestinal syndromes video series, and it will be about the clinical overview. In the first video we talked about each bacteria, each virus, the pathogenesis, the types of infection, the type of tissue, how it will happen, the mechanism, and here we will talk clinically, how we can see it. It will be divided into few syndromes that we will discuss each alone. And during this video we will be zooming in and out, and usually it will be in the center what we are trying to discuss. So let's start with the clinical overview. First part will be the general. As you can see, GI infections, they can manifest with distinct clinical syndromes. These syndromes can be upper or lower. The first upper syndrome is acute vomiting, where the only symptom we will have is profuse vomiting and sudden vomiting of the patient with no diarrhea. Then the others can be watery diarrhea, profuse water diarrhea, invasive diarrhea which has blood or mucus which we call dysentery, persistent diarrhea, or enteric fever. The enteric fever is the only one that has more extra GI manifestations from the other one. We will discuss each one alone, and then we will come back to our main table, which will be like a recap for everything. First of all, we start by acute vomiting. Acute vomiting sometimes is called the stomach flu. It is frequently caused by norovirus or bacterial food poisoning. First of all, norovirus gastroenteritis. Usually and typically it's mild in healthy adults. The hospitalization and death are more common in specific genotypes, which are 2 and 4. And in young children, the elderly, and the immunocompromised, we can find high mortality and hospitalization from norovirus clinical enteric syndrome. The acute vomiting caused by norovirus can give us metabolic, dehydration, and intoxicating effect, which can lead into the hospitalization and death of our patients. Bacterial food poisoning results from the ingestion of preformed toxins outside the host, which means that not the bacteria itself is the source of the infection, but more the toxins made by those bacteria and left in the food that we are ingesting. That's why we don't need to wait for the bacteria to adhere and invade or have pathological symptoms on our gut. The toxin will be already, and that's why we will have a really small incubation period, which can be from 1 to 6 hours, but usually it's less than 12 hours, and it can last from 12 hours to 24, but generally is less than 12. One of the most prominent types of this toxin is produced by staphylococcus. These staphylococci produced toxins, they can be produced especially in starchy food, and this starchy food, when left on different temperatures, can have this toxin, especially that the streptococcus can multiply at different ranges of temperature. And the another type is the Bacillus cereus. Bacillus cereus is another type of bacteria that can also live in starchy food, like fried rice, and in difference from it and staphylococcus. The staphylococcus thrive in starchy and in high protein foods, while Bacillus cereus it's only in starchy food. It has a short incubation period, which can come from 1 to 6 hours, and it's mediated by a neurotoxin similar to the staphylococcal toxin. It has a longer incubation period, which can sometimes go from 8 to 16 hours, or can be 1 to 6 hours, depending on the amount ingested. And depending on the type of toxin. The short form of toxin, which has a small incubation period, similar to the one in Staphylococcus, it's the staphylococcal type neurotoxin, but they have another toxin, which is an enterotoxin, which resembles the E. coli heat-liable toxin. The difference is that this enterotoxin will have a specific effect on our gastric cells, while the neurotoxin will have a specific effect on the neural ending that control our gastric cells. Since it is heat liable, preparing the food with heat will destroy this toxin. So, if the food is left to cool slowly or remains at room temperature after cooking for a long time, these organisms will multiply and will have their toxin produced inside our food. We don't usually confirm such a diagnosis. The diagnosis is made clinically, and it is possible, but we do it only if we have epidemiological investigation, where we have some kind of outbreak of norovirus, for example, or an outbreak of food poisoning. Then during this situation, we can make an investigation for the specific syndrome that's happening. Here we have a table which has multiple food ingestion toxicities. Not all of them will have the same symptoms, but most of them will have vomiting as the main symptom. We have histamine fish poisoning when we have a lot of histamine precursors inside the fish that gets converted to histamine, will give us vomiting, flushing, and as a side effect of overdose of histamine. This syndrome will have diarrhea. It is usually in fish who has high fat content like mackerel, scumbria, tuna, and bluefish, or mahi-mahi, which is the dorado in Mediterranean countries. We have Bacillus cereus, that's the emetic syndrome, which means that it's because of the enterotoxin that's produced, the staphylococcal enterotoxin. The median incubation period is 2 hours, but it can be from 1 to 6 hours, and the most prominent symptom is vomiting. The common vehicle is fried rice because it needs starchy medium to reproduce. Then we have the ciguatera, which we'll not go into since it's not really into our epidemiological profile. Then we have the Staphylococcus aureus, that's median to 3 hours and has a 1 to 6 hours median incubation period. It is has the same incubation period with Bacillus cereus because the emetic toxin responsible for the emetic syndrome of Bacillus cereus is the same by structure as Staphylococcus poisoning. That's why the most common symptom will be vomiting. Sometimes we can find diarrhea, but we will never see fever in acute vomiting. The common vehicles are protein foods that contain high protein content when left on the table, when left in open spaces. the bacteria can multiply and we will get the symptoms. Then we have the bacillus but the diarrheal syndrome. This one is not an acute vomiting syndrome. It's more a diarrheal syndrome, but since it's made with toxins, it's still in the same table. The toxin has a median incubation period of 9 hours, but can range from 6 to 16 hours. And we will have strong abdominal cramps, and it needs protein to produce this syndrome and this toxin. It's easier to remember because this toxin is really close to the E. coli toxin, and that's why it will have an incubation period closer to the E. coli incubation period, and a vehicle, which is beef, pork, and chicken, that is also similar to the E. coli vehicle. And this is the acute vomiting syndrome. We will have a specific video only on acute vomiting, which will be on the specific treatment diagnosis of each one of those agents. And we will go especially deeper into the norovirus, since it can give us small outbreaks in really small confined healthcare areas. Acute watery diarrhea, or otherwise called diarrhea without fever, is the most bacteria and non-bacterial enteric pathogen that can cause watery diarrhea, and consequently this syndrome is not characteristic for any single organism. We have too many etiologies responsible for this syndrome. So we will talk about the common causes. We will have in children a high incidence of rotavirus, especially for those non-vaccinated. In older children, we will have ETEC, and in adults, which is enterotoxic E. coli, and you can have norovirus. Now, norovirus has become the most common acute GI illness in children and adults in the United States, which can tell us that the more we go into better infrastructure and better healthcare systems, the more we will have viral problems and less bacterial problems of GI. Another species of virus that can give us is the adenovirus 40 and 41. They can cause acute watery diarrhea, and especially in children younger than 5 years. These two viruses are important because for all the patients who will come with acute watery diarrhea, we will have them studied for these viruses as a screening. In other countries they don't do it, they just go clinically, and in some countries they do it. But the thing to remember that with young children, we should always think about viral infections, since they are sitting in crowded places with other kids, everyone is touching everything, everyone is touching their mouth, and it's really easy to get these viruses in such facilities. Another type of watery diarrhea that we should really look for, because it has a small different type of water diarrhea. Since all water diarrheas come without fever, sometimes it can be mistaken as non-serious, and most of them are not. They can be really self-limited and go by themselves. But one of the most serious water diarrheas is Vibrio cholera, or the cholera infection, and it should be considered, especially when the diarrhea purging is really profuse and has a rice water consistency. It's like when we water the rice to clean it, and we have this milky white liquid coming out. This milky white liquid is really similar to the consistency of the watery stool that comes out in cholera, and we might have projectile vomiting. This is characteristic for cholera and really fast dehydration. The patient will have high dehydration, hypokalemia because he is losing a lot of fluids with a lot of electrolytes. And this can really touch healthy older children and adults which can die from it. And it's really actual in our world now because we are within the seventh pandemic of the cholera. And cholera has been sweeping multiple areas, especially after big disasters. For example, the earthquake in Haiti, the Syrian war, the earthquake in Turkey, and now it has been expected with multiple areas where the facilities has been broken. Another type of organism that causes this diarrheal infection with no fever is the enterotoxin of Clostridium perfringens. It causes moderate to severe abdominal cramps and watery diarrhea. The heat-resistant spores of Clostridium perfringens can survive in cooked meat for long times. That's why we should think about it. But it's still self-limited and clinically non-relevant for us to actually know the diagnosis, since the treatment will be the same. The only one where we should know the diagnosis are the viruses if we are doing epidemiological studies, or cholera to start an antibacterial treatment. So as we said, in most cases, the acute diarrhea of water diarrhea does not need specific microbial diagnosis, and the treatment should be focused on fluid repletion, and antibiotics are not indicated unless if they shorten the duration of the illness. For example, in Vibrio cholera, the antibiotics can shorten the symptoms, decrease the water loss, and help save the patient that are at risk. This is acute watery diarrhea with no fever, as we said. All of these organisms will give us an acute watery diarrhea, but will never give us fever. The next syndrome to talk about is acute diarrhea with fever, or what used to be called dysentery. Any presence of blood or mucus in both in fecal matter is most probably the result of inflammation in the small bowel or in the colon in response to an invasion of bacterial infection, which is the definition of dysentery. Dysentery is diarrhea with inflammation, which leads to fever. And one of the main symptoms of inflammation in the bowel is when you will have blood or mucus in the stool. By direct macroscopy, we can find fecal leukocytes, which can also give us a small clinical hint that the infection we are dealing with is dysentery and not acute watery diarrhea. So fever usually accompanies invasive diarrhea and result from pronounced mucosal inflammatory response. The mucosa will be inflamed. Sometimes this mucosa will have blood vessels under it, which will start leaking blood. Will have hyper secretion, the permeability of the blood vessels will be higher, and you will have more secretion, and you will have more of the toxins and the pathological changes of these bacteria. And most of the time, the endotoxins of these bacteria will come into contact with our blood and give us the systemic symptoms like fever. One of the major causes in the United States are Shigella or Shiga toxin enterocoli, which can be sometimes without fever. But then we will know that this is dysentery by the presence of blood and mucus, even if we still don't have fever. Clostridium jejuni, and non-typhoidal salmonella. Campylobacter jejuni. They will give us this syndrome. One of the important reasons why we should differentiate them, because one of the complications of dysentery is hemolytic uremic syndrome. It's when we will have really high release of specific toxins from this blood vessels inside the mucosa. They will take all these toxins, and these toxins can lead into hemolysis. This hemolysis will increase the production and will increase the effect of this toxin, especially on the kidneys. And this toxin usually is phage-mediated Shiga toxin and will increase the risk of hemolytic uremic syndrome. Well, we'll have the specific triad, which is fever, hemolysis, anemia comes from hemolysis, and acute renal failure. Any patient with fever, acute renal failure, and hemolysis should be checked for hemolytic uremic syndrome. This microangiopathic hemolytic anemia and thrombocytopenia, which results from it, is usually by Shigella dysentery serotype 1. This will have its own video within the video of diarrhea with fever or dysentery video, which will come later in this series. Another type of diarrhea that we are looking into is chronic diarrhea, which is diarrhea that lasts more than 2 weeks. All the other types of diarrhea are usually self-limited and will go by themselves within 2 weeks. The infections that can be for more than 2 weeks are enteroaggregative E. coli. For example, because this enteroaggregative E. coli have specific aggregation factors, where this bacteria will be in clumps inside our GI, and the immune system cannot get into it. That's why it will be really slowly eliminated. That's why we will have the symptoms for more than 2 weeks. Another type is parasitic infection. Any kind of parasitic infection will be for longer than 2 weeks, especially if we take histoplasmosis or amoebiasis. All of them will have long time. For example, we can have cryptosporidium or cystospora. These types of parasitic infections are specific usually for HIV infected patients or immunocompromised. So, many cases the persistent diarrhea are triggered by a previous episode of acute enteritis, and diarrhea is just the inability to restore normal resorptive function after diffuse intestinal injury. That's why when a patient is having dysentery or acute inflammatory diarrhea, which is usually invasive type of diarrhea, we should check for the etiological factor to be able to differentiate it from just normal acute diarrhea that's already past, the infection itself is past, but we are having now a long recovery period, or if it's a chronic infection that is still going on. Another type of diarrhea is associated with malnutrition and chronic enteropathy and should raise suspicion for underlying illness, especially if you are having the classical enteroaggregative or E. coli or the parasitic infection, because the biggest risk factor other than immunodepression to getting these infections that persist is malnutrition. Any HIV infected person with unexplained diarrhea can have this symptom And usually it is an HIV defining or AIDS defining syndrome, and it can be in people who are not taking their HIV drugs on time, or in patients who don't know that they have HIV. It can be primary diarrhea because of the virus itself, or it can be because of immunodepression that gives other infections the opportunity to get into this area. And now we go into enteric fevers. The enteric fever usually is a febrile illness that follows systemic spread of Salmonella enterica after the local invasion of the gut, and it can be called typhoid fever, especially if paid by serovar typhi, and paratyphoid fever if it's by Salmonella enterica, serovar paratyphi A, B, and C. Usually these bacteria, when they come into contact with our gut, they invade it with minimal symptoms. Then they go inside our bloodstream and colonize the lymphatic nodes of our GI tract. They can persist in the Mears patches, and they will have systemic infection. This invasion of the blood system and the Mears patches can give us perforation and necrosis and multiple systemic symptoms. So predominantly we'll have persistent fever, and we can have hepatosplenomegaly, abdominal pain, neuropsychiatric symptoms because of high intoxication, perforation of the distal ileum, especially when we have congested Mears patches, can have really serious complications. So any person who has enteric fever should be really closely observed, because any kind of complication of this type will need surgical intervention. And it's important to understand it, because this type of syndrome will need antibiotics and will need different treatment than other syndromes. And now we go into complications. The most common complications within the GI tract are pseudoappendicitis, especially from Campylobacter jejuni, and exacerbation of underlying inflammatory bowel disease. So patients who have Crohn's disease or ulcerative colitis will have exacerbations and remission episodes because of these other infections. Then we can have non-GI complications, for example, bacteremic spread of the organism, systemic action of a bacterial toxin, for example, hemolytic uremic syndrome, and post-infectious reactive arthritis. Here we have a table with these complications. First of all, one of the most common complications is bacteremia. It's especially in Salmonella and Campylobacter and Shigella, all the invasive types. It is a particular concern in HIV infected people or in people with thalassemia and spherocytosis and other type of hematological disorders. We can have seizures. In Shigella species, it is especially in children because of the strong action of the toxin and the high fever that we get. Chronic diarrhea can be in travelers, and usually it can be because of, and sometimes it can be mistaken as infectious, but it can be because of lactase deficiency. And when we have bacterial overgrowth of lactase producing bacteria, we will have something like lactose intolerance, and this can be sometimes mistreated as a chronic infection, while it is more like an allergic type of illness. So we talked about all the bacterial pathogens that's caused by that can cause the irritable bowel syndrome or exacerbation of inflammatory bowel disease. All of them can do it. It's just they tip the balance that was so weak inside our gut or the gut of these patients. Reactive arthritis, especially in Salmonella and Shigella, is specific to specific people who have HLA-B27 genes, and they will have some kind of autoimmune reaction to the same HLA receptor and the same receptors on Salmonella, and that's why they will have reactive arthritis. Hemolytic uremic syndrome is a Shiga toxin producing bacteria specific syndrome, and it has the triad we talked about: hemolytic anemia, renal failure, thrombocytopenia. We can add fever to this triad. And Guillain-Barré syndrome, but it's quite rare. So, diagnostic approach. First of all, the most important clinical approach to diagnosis is history and physical examination to any GI illness. We should know the epidemiological history. It should focus on recent travel, specific diet, animal exposure, current medication, or medical history. For example, underlying conditions or immunosuppressive conditions. As we saw in the previous video, each one of those information can kind of orient us clinically to a different group of pathogens. And the nature of the symptoms, especially if we classify them with our classification system that we are using now, can give us vomiting, diarrhea, or enteric fever, and the type of diarrhea. And this will help us get even closer and closer to the group of pathogen that is causing our disease. And if the patient has a history of antibiotic therapy, then we should look at Clostridium difficile, which is AB-associated diarrhea, or pseudomembranous colitis, and we should look for it. And the test is quite easy to do it by stool exam. So, in kind of any ongoing outbreaks in the community or the travel destination, knowledge of these epidemiological data or knowledge of these new outbreaks is a really big plus to our physician to be able to diagnose fast and start the treatment fast. Physical examination is important and should focus on vital signs, especially in fever and orthostasis. We should check volume status, check if the patient is hypovolemic or not. We should check for abdominal tenderness to see if we are having any of the complications. We should check for complications outside of the GI tract and the sensorium. The patient's consciousness should be tested. The patient's hydration status should be tested. And we should check for electrolyte disturbances outside of the GI tract. And we should check complications of the GI tract. So, for purposes of directing the diagnostic evaluation of diarrheal disease, we can divide it into two types. We can divide it into community or traveler diarrhea, which goes into all of what we discussed in the upper classification, or we have an extra classification or an extra point of classification, which is nosocomial diarrhea and persistent diarrhea. In most cases of community acquired or traveler's diarrhea, we don't need to go into a thorough diagnostic search because most probably the infection will go by itself, and if it becomes into persistent, then we will go into big diagnostic search. But if it's a nosocomial diarrhea, it is especially a common complication of hospitalized patients, where it could be Clostridium difficile, which is the most common, or it can be acetotoxic, Klebsiella oxytoca, or enterotoxin producing Clostridium perfringens. All of these agents will need antibiotic therapy, and that's why we should be able to differentiate them. And just by differentiating by community acquired or nosocomial diarrhea, it will be easy for us to be able to know which one which is our next step. If it's nosocomial, we will directly do the test for these three etiological factors. If not, then we will just rehydrate the patient and wait. The presence of fever or blood in stool should prompt evaluation of fecal specimen for commonly associated pathogens including Salmonella, Shigella, Campylobacter, and Shiga toxin like Enterocoli. This is easy because we just take the stool and do stool culture, and we will get the results in a few days. During this time, it will be safe to administer antibiotics to this patient if needed. Most cases of diarrhea in hospitalized patients are non-infectious, and they are usually due to medication or enteral feeding or any underlying illness. That's why if a patient which is hospitalized gets diarrhea, we don't jump into the conclusion that he has nosocomial diarrhea. We should check for nosocomial diarrhea and keep in mind that it can be just the change in diet, it can be stress on the organism, it can be a change in GI motility and GI side effects because of other drugs. Then, if we have persistent diarrhea in immunocompromised host, this is a specific type of diagnostic search. We should consider a big array of etiological factors, and we should look for Giardia, we should look for other type of Cryptospora, Cystospora, Microsporidia, and of big importance, we should look for Mycobacter avium complex. All these type of non-tubercular mycosis, we should look for them. As we said, culturing is the mainstay of invasive diarrhea. Most laboratories are able to culture them. They are able to test for Clostridium difficile and Shiga toxin Enterocoli by checking for their antigen in the stool. But in any place where we are sitting, where we are practicing medicine, we should be in contact with our laboratory to know what the test that they can give us, because the type of tests are different according to the country's protocols and according to the country's epidemiology and the material capabilities of this country. So if we have the capacities to do these tests, we should be able to contact our laboratory to know which tests exactly we have the capacity to do. And if we are doing culture-dependent diagnostic tests, we should check for antibiotic susceptibility data, especially that in big areas of the world we are having more and more antibiotic resistant diarrheas. The specimen of choice for laboratory testing is loose stool that takes the shape of the container. It's not always possible, but that's the ideal. And in pediatric patient, the first specimen detects 98% of the identifiable enteric pathogens. That's why we need most of the time only one specimen. But in the adults, it's a lot less. That's why one sample is taken for children and 2 samples are taken for adult patients. And it should generally be sufficient. Now we go into therapy. Rehydration is the mainstay. The biggest pathogenic factor in all of these infections is dehydration, where the patient loses a lot of fluids and these fluids need to be replenished. The vast majority of cases, the infection can be treated only by oral rehydration salts. These are by WHO guidelines reduced osmolarity solutions that contain sodium, glucose, and a lot of the time can contain potassium. This is recommended by WHO, especially in resource-limited areas. A diet of easily digestible food is commonly recommended, and all the randomized studies still support the continuation of feeding in children. So if a child is feeding from his mother, we should not stop him if he is having diarrhea. Adults with severe dehydration should get IV fluids. Usually we use lactated Ringer with 5% dextrose, but we can also use normal saline. But the disadvantage of normal saline is that it does not contain potassium to correct losses or to correct acidosis. So usually if we have good capacities, we should be able to give our patient lactate Ringer with 5% dextrose with a proportion or ratio of 1:3. Or if we are giving saline with dextrose 5%, we can give him a 1:5 ratio or 1:3, depending on the case you are having. And correcting the potassium should be calculated depending on the patient's potassium level and how it should be, and it can be added directly into the fluids, or we can add bases. But usually normal saline with glucose is enough, unless you are having signs of potassium deficiency. Now we go into a controversial area of our therapy, which is antibiotic therapy. For acute bacterial gastroenteritis, which is all of these syndromes, antibiotic therapy depends on the pathogen. For example, if we have Vibrio cholera or enterotoxic E. coli, especially the 139 serotype, antibiotics are recommended for moderate to severe illness. They shorten the symptom duration really well. In Campylobacter, antibiotics are recommended only in patients who have high risk, like immunocompromised, kids, or old people, and pregnant people. Antimicrobial agents, especially in early stages of invasive diarrhea by Shigella or enterotoxic E. coli, if it's given too early, they increase the risk of hemolytic uremic syndrome, since when these bacteria will get stressed by this antibiotic, they will increase their production of the Shiga toxin. And for the last few decades, we have seen a steady rise in antimicrobial resistance in enteric pathogens, and especially in the developed world. We have seen MDRs or multi-drug resistance in non-typhoidal salmonella, in Shigella species, and in Vibrio cholera. These identical strains of antibiotic-resistant pathogen, they have been demonstrated to infect both humans and farm animals that have been the source of those infections. So the fact that you are giving a lot of antibiotics to farm animals can be one of the reasons why we are having increased resistance of these bacteria that we are getting from our animals. Another controversial type of treatment that is usually asked by the patients is antimotility agent. All the patients don't like to go to the bathroom every few hours or a few times per hour. That's why they will ask us to give them antimotility agents. But if we are having invasive organisms and we don't have effective antibiotics, the antimotility agent will aggravate the infection and can lead to really increased absorption of Shiga toxin and increase the hemolytic uremic syndrome risk. That's why antimotility agents should be given only after we have proven that our antibodies are working on our infection. And they should be avoided with patients that have dysentery syndrome. Any patient with dysentery syndrome or acute diarrhea with fever should not be given antimotility agents. And if the patient has antibiotic therapy that is working, we could give him antimotility agents, and it is safe to be given in travelers, especially if they have travelers diarrhea. Antimotility agents are safe because travelers diarrhea has too many factors, and changing only one factor will not increase or decrease the likelihood of complications or the infection staying. And now prevention. The mainstay of prevention is limiting the spread of the organism within the community or from person to person. And since it is fecal-oral and the only route between feces and the mouth is hands, usually washing hands is more than enough as prevention. That's why community-acquired bacterial GI infection that are not foodborne, that are fecal-oral, can be prevented using washing hands. And if they are foodborne, then depends on monitoring the food sources for bacterial contamination. So for example, when a chain of restaurants has a big batch of produce that has a small outbreak or had incidents of multiple people having diarrhea, it should be tested, monitored, and thrown away if it has toxins. And usually it's just common sense. That's why we have big expiration dates. That's why if we see any kind of changes in our food, we should just throw it away, especially if these changes are correlated with bacterial growth. Like, we will have foul smell, we will have change in the acidic profile, we will have change in the color. All of these are indications that it's time to throw away our produce. And another type of prevention, it can be vaccine. In the current world stocks and the current approved vaccines, you only have 3 vaccines. The first of them are the rotavirus vaccines, and they can be divided into a pentavalent rota vaccine with 3 doses given at 2, 4, and 6 months, or a monovalent vaccine with 2 doses at 2 and 4. The 2 and 4 vaccine has been getting more popularity lately. Then we will have the cholera vaccine, which is killed whole cell oral cholera vaccines, which are the monovalent O1 vaccine supplemented with the B unit of the cholera toxin. And the second is a bivalent cholera toxin with the O1 serotype and the O139 serotype. There are 2 current approaches to typhoid vaccination. The first of all is the live attenuated vaccine, given in 3 doses that can give us a 50% protection for the subsequent 3 years, or a parenteral or IV virulent polysaccharide vaccine, which give us 60% protection over the upcoming 2 years. And now to the extra department. We will have the antibiotics that we can give and a small order of action. But before getting into it, we will go back and revise our table that gave us the main symptoms. So, The clinical syndromes that we are looking for by this classification are acute watery diarrhea. The signs are loose stools with no blood, minimal mucus. They can have occasional vomiting. Fever might be present, but only low-grade fever, and malaise. The mechanism is just local infection in the gut. It's just an infection. The example of such pathogens are norovirus, enteric adenovirus, enteropathogenic E. coli, enterotoxic E. coli, Cryptosporidium, and Bacillus aureus. Syndrome number 2 is dysentery or acute bloody diarrhea. We will have loose stool with gross blood and mucus. We will have fever, which is not low grade. We will have abdominal cramps. It might have tenesmus. And the patient will be clinically toxic, not only malaise. The pathogenic mechanism is local invasion. The invasion will give us the extra signs and will give us the clinical syndrome of dysentery. These are Shigella, enteroinvasive E. coli, Campylobacter, Entamoeba histolytica, non-typhoidal Salmonella, and Yersinia enterocolitica. And sometimes Clostridoid difficile, but Clostridoid difficile is more of an antibiotic-associated dysentery syndrome. Another type of acute watery diarrhea, which in this table is its own category, is profuse purging, which is copious watery stool like rice water, low-grade fever, and high signs of dehydration. It is toxin-mediated, and it is by enterotoxigenic E. coli and Vibrio cholera. It is important because this is one of the most dangerous types of GI syndromes. We can have persistent diarrhea. It's the same as acute diarrhea, but for 14 days. It has local infection and with immune compromise of the host. It's because of E. coli or parasites like Giardia, Cryptosporidium, and Mycobacterial avium complex. Then we have acute vomiting or stomach flu, which has sudden onset of vomiting with little to no diarrhea. It is because of local infection of the gut or because of intoxication, local infection by norovirus, or intoxication due to Staphylococcus aureus or Bacillus cereus toxins. And then we go into enteric fever. We have fever and lymphadenopathy. The lymphadenopathy of the lymphatic system of the gut is the mainstay of enteric fever. We'll have local invasion of the gut with systemic spread, and that's why we will have the systemic symptoms like fever, a really high fever. It's usually caused by Salmonella enterica. The serovars are Salmonella typhi and Serovar paratyphi A, B, and C. And as you can see, all the etiological agents that can cause dysentery, if they didn't invade enough inside our wall of the gut, they will just cause acute watery diarrhea. And now back to our extras. The extras are always at the end of our mind maps, which can be found on our Patreon page. The link is in the description. We will talk about antibiotics. Here we have multiple examples and with multiple differences of usefulness. For example, antibiotics have demonstrated benefits in randomized controlled trials and are indicated for patients with moderate to severe disease. This level of usefulness is specific for Shigella, enteroinvasive E. coli, enterotoxigenic E. coli, Vibrio cholera, and Aeromonas. Here we have the second stage of usefulness, where antibiotics have demonstrated only modest benefits and only with severe or prolonged illness patients, or abnormal hosts like immunocompromised, or young and old, like children and really old people. This is Campylobacter jejuni. Another type of usefulness or another class of usefulness is they demonstrated no clear benefit and may prolong the excretion of the organism, especially if the patient will become a chronic carrier of this state. This is for non-typhoidal Salmonella species. And antibiotics should be used only in select circumstances. This is if we will have extra GI complications like perforation and so on. And if we look at antibiotics that have demonstrated no clear benefit, and on the other hand it showed more of a risk for complications such as hemolytic uremic syndrome, we could see that starting antibiotics too early in Shiga toxin producing E. coli will lead to an increased risk of hemolytic uremic syndrome. So unless we have really serious complications or really serious illness, antibiotics should never be given for such patients. So now we go into our tree of action. We start by having a patient who comes to us with diarrhea, nausea, or vomiting. We assess the duration of the symptom, the severity of the dehydration or other symptoms like fever, blood in the stool, weight loss, and sensorium, which is the consciousness, and the epidemiological features. And like this, we can classify our patients into 3 categories. For example, nosocomial diarrhea, which are after 3 days of hospital stay. We should always get cultures and test for the most common etiological factors like Clostridioid difficile or non-infectious causes. If we have an immunocompromised host with persistent diarrhea, we should culture or test for the most common factors like Giardia, Cryptospora, Cyclospora, Cystospora, and Mycobacter avium complex. And if we have just normal community acquired or traveler's diarrhea, we classify it into water diarrhea, where we just treat the patient without giving him any specific diagnostic tests unless we have part of a cholera outbreak or we think that the patient might have cholera. And if the patient has fever or blood in his stool, which is no longer just water diarrhea, it's more of a dysentery syndrome, we should culture the stool and check for Clostridium difficile in the stool. And at the end of this, thank you for watching this video. At the end, I just would like to add that Clostridium difficile by the new classification is called Clostridioid difficile as a new genus by itself, but sometimes in some books it's still called Clostridium, especially in the books that have not been updated yet. So if in any of the videos the term is used interchangeably, it's okay, and I think all of the viewers will understand that they are the same organism. You are talking about the same organism. And thank you for watching. See you in the next video where we will discuss each of these clinical syndromes alone and analyze it by itself. Thank you for being here. It would be a real pleasure for you to subscribe to this channel and hope to see you soon.